you can choose which of the interpretation you want, because we will have some speakers talking in French and English today. We have the Q&A box where you can drop your questions as we go on, as our panelists continue. And I have the pleasure to hand over to the chair of this session in the person of Professor Oye Gureje. Over to you, Prof.
Thank you very much, Dr. Abdulaziz. My name is Oye Gureje. I teach at the University of Ibadan in the Department of Psychiatry. So you're welcome to this fourth webinar in the series. Today we are going to be focusing on the topic, building resilience in healthcare workers, including dealing with work-related stress and burnout. We have three distinguished members of the panel that will be speaking each for about 15 minutes. And then we are going to have about half an hour of question and answer. And that we expect that you will put your questions on the panel on question and answer, and I will be selecting from those and giving this to the panelists to address. We may also ask one or two or so people to speak directly to the microphone and ask the question from the panelists. So it's my pleasure then to introduce the three panelists who will be speaking to us this afternoon or morning or evening, wherever you are based. The first speaker will be Dr. Bibilola Oladeji, who is a psychiatrist and senior lecturer at the Department of Psychiatry at the College of Medicine in the University of Ibadan in Nigeria. She's currently the head of Department of Psychiatry in that university. She's also a consultant psychiatrist at the University College Hospital. Her main interests are in psychiatric epidemiology, implementation research, especially in the integration of mental health care with the general health services. Our second speaker will be Dr. Jaco Russo, who is a clinical psychologist currently in private practice in Cape Town, South Africa, and has been for 26 years, I'm sorry. He consults with children, with adolescents, adults, and families using cognitive behavioral therapy approach. Jaco is a founding member of the Center for Cognitive Behavioral Therapy, is an internationally certified cognitive behavioral therapist, and is an associate fellow of the Albert Ellis Institute. He is involved in developing and providing training in CBT to mental health professionals, and has a long-standing interest in CBT, which culminated in a PhD study on the treatment of adolescents with PTSD at the Department of Psychiatry in Stellenbosch University, where he is also an extraordinary senior lecturer. Our third speaker, a member of the panel, is Dr. Eric Bowie, who is professor of psychiatry at the University of Saint Normandy and adjunct faculty at the Massachusetts General Hospital, where he served in different leadership capacities at the Center for Anxiety and Traumatic Stress Disorders. His research focuses specifically on understanding the mechanism and improving the treatment of anxiety and stress-related conditions, including using mind-body approaches. To date, he has published over 150 scientific articles and book chapters, and has edited 2 textbooks in the field of anxiety disorders, post-traumatic stress disorder, complicated grief, and related disorders. He currently serves on the board of directors of the International Society for Traumatic Stress Studies as associate editor of the European Journal of Psychotraumatology, and also as editor-in-chief of the International Journal of Mental Health. Each of the panelists will be speaking with us to us for about 15 minutes, following which we will then have a period of question and answer. But before we get to that, we're going to listen to Fadi Niyotungura, who is going to give us the latest information on the COVID-19 in our region, that's in Africa. So he's going to do that for a few minutes, and then we get on to the first member of the panel. So Fadi, this floor is yours.
Thank you so much, Professor Guleje, for the welcome. So for the interest of French-speaking participants, I'm going to speak in French. I hope that those who cannot now understand French, there's an icon for English, interpretation. Please click on it. You can get the direct interpretation. Sorry, I'm getting troubles with sharing of screen, but I hope it will allow me. Okay, can you see it? Can you see my screen? Can someone confirm, please?
Yes, we can see. Go on.
Okay, okay. Moi qui vous parle, je suis Tadene Itongira, je suis officier de santé publique à Africa CDC. Donc, je vais vous présenter la situation épidémiologique de la COVID en Afrique. Donc, cette diapositive montre la situation épidémiologique de COVID-19 dans le monde. La carte à gauche montre la répartition des cas de COVID-19 par pays dans le monde. Et la couleur plus foncée indique les pays qui ont signalé plus de 300 000 cas depuis le début de la pandémie en janvier 2020. Ici, 24 pays, dont l'Afrique du Sud, ont déjà signalé plus de 300 000 cas à ce jour. Et le panneau de droite est une courbe épidémique montrant la tendance des cas de COVID-19 signalés quotidiennement par les 6 zones géographiques de l'OMS. La région PAO est celle qui a signalé le plus grand nombre de nouveaux cas par jour. Et l'Afrique, à la couleur rouge foncé, représente actuellement 4% de tous les cas de COVID-19 signalés dans le monde. Ici, plus de 51 millions de cas ont été confirmés à ce jour, dont plus de 9 millions, dont plus de 1 million 200 000 cas sont morts avec un taux de létalité de 2,5%, et ce dans plus de 200 pays et territoires. Et cette diapositive montre la tendance des cas de COVID-19 de février à ce jour. Le graphique épidémiologique indique le nombre de nouveaux cas signalés par jour et la moyenne mobile si 7 jours est indiquée par la ligne rouge. Au cours des 4 dernières semaines, on observe une tendance à la hausse de nouveaux cas dits aux régions du Nord et du Sud, avec un total de plus de 1 900 000 cas qui ont été signalés, plus de 45 000 décès, avec bien sûr un taux de létalité de 4%. Mais la bonne nouvelle, c'est que 85% de tous ces cas ont été guéris. Et ce tableau montre la répartition des cas, décès et guérisons des cas de COVID-19 par région de l'Union africaine. Au cours de 24 heures, plus de, je dirais bien sûr les 24 heures passées, plus de 11 400 nouveaux cas, dont 224 nouveaux décès et plus de 11 420 nouvelles guérisons ont été signalées dans 57 États membres de 5 régions. Une grande partie, comme je l'ai dit dans la deuxième diapo, une grande partie de tous ces cas ont été signalés dans les régions du Nord et du Sud. Et depuis que l'épidémie a été signalée en février, on a recensé plus de 1 917 960 cas dans 55 États membres. Ici, malheureusement, 46 272 cas sont morts, avec bien sûr 1 622 226 cas qui ont été guéris disons plus de à peu près 85%. Et cette diapositive montre les cas COVID cumulés par État membre de l'Union africaine au 12 novembre 2020 à Nevers, aire de l'Afrique de l'Est. Ici, nous avons 22 pays qui apportent plus ou moins 5 000 cas, 11 pays qui apportent entre 5 000 et 10 000 cas, 14 pays qui apportent entre 10 000 et 50 000 cas, 7 pays qui apportent entre 50 000 et 500 000 cas, et un seul pays qui apporte plus de 500 000 cas, bien sûr, c'est l'Afrique du Sud. Et cette diapositive montre l'incidence cumulée des cas de COVID-19 par État membre de l'Union africaine au 12 novembre 2020 à Nevers, bien sûr, aire de l'Afrique de l'Est. Ici, nous avons 4 pays avec moins de 10 cas pour 100 000 habitants, 24 pays entre 10 et 100 cas pour 100 000 habitants, 14 pays avec entre 100 et 500 cas par 100 000 habitants et 7 pays avec, bien sûr, plus de 500 cas pour 100 000 habitants. Et cette diapositive montre les nouveaux cas COVID-19 signalés par 1 million de personnes par jour par État membre de l'Union africaine. Ici, nous avons 47 pays qui apportent moins de 40 cas par 1 million d'habitants par jour. Un pays qui apporte entre 40 et 80 cas par million d'habitants par jour et 4 pays qui apportent plus de 100 cas par million d'habitants par jour. Et enfin, cette diapositive montre bien sûr les tests de COVID-19 réalisés en Afrique entre bien sûr le 14 février et le 12 novembre 2020. Comme vous pouvez le constater sur l'écran, nous avons à ce jour enregistré 19 700 000 tests en Afrique et cela fait 10,3 tests par cas déclarés avec bien sûr un taux de positivité de 9,7. Voilà, brièvement, c'était ça comme situation épidémiologique de la COVID en Afrique. Je vais donner la parole au professeur Goulege pour la poursuite du programme. À vous.
Thank you very much, Thadi. If there are questions for you too, when we get to the question and answer, I will let you know.
No problem.
So we go to the first member of the panel, Dr. Oladeji, to give us our own talk. Thank you, Dr. Oladeji.
Good afternoon, everyone. And the slides, should I share the slides from my end?
Yes, please. Can you share, if you can share your slide, your screen?
Okay. Okay, I hope that worked.
Yeah, that's fine. That's yeah.
Okay, good day, everyone. I would like to appreciate the organizers of this program for inviting us to lead this discussion on building resilience in healthcare workers, including dealing with work-related stress and burnout. I will be providing a background on which the other speakers will be building on by taking us through an overview of burnout and work-related stress among healthcare workers, starting by looking at what is known in Africa and associated factors, and then to now come down on what happens during an epidemic situation like we are currently in with the COVID-19. Burnout is essentially a product of work-related stress, and the ICD-11 includes burnout not as a mental health disorder, but as an occupational phenomenon, which is, it's reported specifically in the occupational context. In the next slide, I just want to take us through how the definition for burnout that is provided in the ICD-11, which is a bit more detailed than in the previous versions of the ICD. The ICD is the International Classification of Diseases and Related Health Problems, a document of the World Health Organization. So it is defined as a syndrome which is conceptualized as resulting from workplace stress that has not been successfully managed. And it is described in 3 dimensions. The first dimension is feelings of energy depletion or exhaustion. The second is increased mental distance from one's job and feelings of negativism or cynicism related to one's job. And the third dimension is reduced professional efficacy, which can include things like reduced productivity at work. And I think it is worth mentioning this other group of disorders which also develop in relation to stresses. And I'm sure you'll all agree with me that some of the stresses that we're seeing now in healthcare workers exposed to the frontline in the COVID-19 actually meet the standard requirements for the traumatic events that are related to acute stress disorder and post-traumatic stress disorder, which are events that are perceived as an intense threat to life, physical integrity, intense fear, helplessness, or horror, which are some of the things that are happening at the front line. The pictogram just depicts some of the symptoms of post-traumatic stress disorder, which I'm not going to be able to go through because of our time. The rates of these disorders are also known to increase during and after disease outbreaks, such as the COVID-19. Healthcare workers, compared to other workers, are at increased risk for burnout. And several instruments have been used in the past to assess the rates of burnout in healthcare workers. And the most common of them is the MBI, that's the Marshall's Burnout Inventory. This systematic review of burnout among healthcare providers in sub-Saharan Africa included 65 studies from across 15 countries in Africa, found an overall prevalence using the occupational burnout scale for the studies that used that for 51%, and for studies that use the MBI, the rate range between 40 and 80%. And we can see that the reduced personal accomplishment in this study. Coming down to the risk factors, the risk factors that were recognized in healthcare workers in Africa include the workload, when there's shortage of staff, low career satisfaction, and then the hierarchy observed in the profession, especially for the nurses, was associated with increased risk for burnout. Interpersonal professional conflicts, which is usually one of the things that in Nigeria, it's one of the things that we currently are going through, having all these doctor to doctor and doctor to nurse conflicts, are also associated with increased risk of burnout. The protective factors were having good social support and having support of the management. So coming down to what happens when we have infectious disease outbreak like this, the most studied was the SARS of 2002 to 2003. And the map just shows the countries where the SARS at that time, the outbreak occurred. Perceived work-related stress during the SARS epidemic was between 18.1 and 80.1%. Acute stress disorder was found in 40% of healthcare workers, and symptoms of PTSD between 11 and 73.4%, and burnout in 27%. The striking thing about this is that these conditions did not end with the end of the outbreak. After the outbreak, for more than a year, 10 to 40% of healthcare workers continued to have symptoms of post-traumatic stress disorder, and burnout was, especially for the exhaustion subscale, was reported in almost a third of healthcare workers up to 2 years after the end of the SARS outbreak. Some authors are already suggesting that the rates of burnout and stress is higher amongst healthcare workers in the ongoing COVID-19 pandemic. And we are not yet sure what the long-term effect will be. So this is a pointer to the need to begin to develop targeted interventions for healthcare workers going forward. From studies, the few studies that are available on COVID-19 reports that work-related stress occurs in between 37.5 to 81% of healthcare workers. And the striking thing is that the perception of work-related stress differ by profession. For the nurses that are working on COVID-19 wards actually have higher perception of stress compared to those on other wards, while the reverse seems to be true for the doctors. And the sources of stress, the work-related stress that were identified include the shortage of PPE, discomfort from using the PPE, such as difficulty seeing through the goggles, and a lot of workers are beginning to report cracked and irritated hands from the frequent repeated hand washing. The workload also is one of the other factors. The fear of getting infected or infecting family members, which is particularly higher in the nurses. The nurses have a higher perception of fear related to getting infected compared to the physicians. And separation from family, restrictions in eating and drinking while working on the front lines, and the burden of caring for patients were the identified stressors in the workplace. And during the COVID-19, from this study that was done across UK, Poland, and Singapore, 67% of healthcare workers on the Oldenburg burnout inventory had high risk of burnout. For this table, I just looked at those with high risk. If I included a moderate level of risk, the rates are much more higher than this. For almost all the dimensions of burnout, the rates were above 60%. This meta-analysis pulled data from across studies, including the ongoing COVID-19 as well as the previous viral epidemic outbreaks. And the pooled burnout was 28% for pooled prevalence for burnout. Acute stress reaction was about 40% and PTSD of 13% across healthcare workers. And some of the risk factors that have been identified for, especially for healthcare workers working at the front line in the care for patients with COVID-19 was one of the most important risk factors across several studies. But I just need to point out that one earlier study out of China found lower rates of burnout in providers that were working directly with COVID-19 patients compared to those in other areas. But another thing that also came out is that profession also matter. The nurses that were working on the front line had higher risk of burnout compared to nurses on the other wards. Whereas for doctors, the risk for burnout was no different between doctors working on the front line of COVID-19 care and those that were working on the other wards. High perceived work-related stress was one of the most important risk factors for burnout. And the stressors that were reported, particularly in association with burnout, included higher workload, having inadequate personnel. And I would want to point our attention to the fact that healthcare workers, they were kind of drafted or conscripted to go and work in the COVID-19 ward seem to have a higher risk of burnout than those who volunteered to work on those wards. And healthcare workers who had been exposed to COVID-19 and had need for quarantine also had higher rates of burnout. Those with less work experience and where PPE shortages are rife are also at increased risk for burnout. Another thing that was important is that the fear of getting COVID-19 was positively correlated with high rates of burnout, especially on the exhaustion scale, irrespective of what kind of cadre of professional or healthcare worker they are, or irrespective of where they were working. So the fear of getting COVID-19 was a particular important risk for burnout. Younger healthcare workers, females, and those who had maladaptive coping styles were also found to be at higher risk. The important protective factors that were found for burnout in the workplace included having organizational support. So healthcare workers that felt that the hospital management was supportive, and then there were measures put in place in that workplace to support the healthcare workers, had lower risk for burnout. And those who felt that their training was adequate to be at the front line also had a lower risk of burnout. And where healthcare workers were confident that the equipment and infection control measures put in place was adequate, they had lower risk of burnout. But I need to point out that even though they had lower rates of burnout and work-related stress, their mental well-being was not protected by being confident that the equipment and infection control measures were adequate. And the personal protective factors include being resilient and having self-efficacy. And those healthcare workers who had support from family and friends were also at reduced risk. Why is this important? we need to note that burnout is associated with poor quality of patient care. It has been found that healthcare workers that are, especially for physicians who report burnout, had higher rates of self-reported errors in patient care, and were also more likely to reduce their clinical workload. It's also associated with increased absenteeism and increased staff turnover, and this we know will be disruptive to the work rosters and work schedules. Burnout is also associated with increased risk for mental health problems, anxiety, depression, suicidality, substance use. It's also related with sleep problems, muscle tension, and increased irritability. And as I've mentioned before, higher risk of burnout also goes along with higher risk for all these stress-related conditions like the acute stress disorder and PTSD. In concluding my talk, realizing that burnout is a product of chronic workplace stress, it is not just enough to have interventions targeted at the healthcare workers. Interventions must also include measures that can improve the workplace and work practices. So in closing, I would like to lend my voice to that of these healthcare providers, urging the management to protect healthcare workers so that patients can be well protected. Thank you for listening.
Thank you very much, Dr. Oladeji. That's really excellent. So we now know the risk and the consequences of burnout. We're going to be listening now to how to either prevent this or to attend to the problem when it arises. And so we're going to listen to Dr. Jaco Russo, who's going to be talking to us about how to build resilience and manage stress among the healthcare workers. Jaco, so the floor is yours.
Thank you very much. May I just ask that the previous presenter just stop sharing their screen. Otherwise, I can't share my screen. Thank you. My presentation will focus on two things. The main aspect, the two aspects is speaking around resilience as a way of countering potential burnout, and also then referring to the intervention that we developed at Stellenbosch University for frontline workers within the university hospital, and that is Tygerberg Hospital, that we have been running there. So the intervention was developed to assist in building resilience so as to mitigate the risk factors for chronic psychological problems during this time, and also in the period after COVID-19, where people might still continue to have psychological difficulties and struggle with anxiety or mood or PTSD related symptoms and burnout. So firstly, to look at a definition of resilience, the arrows are sort of some of the definitions that have been offered by authors, and then the one that I think is comprehensive and describes our situation well. As one of many possible outcomes to life challenges, resilience refers to a stable trajectory of mental health despite exposure to a serious stressor. predictors of resilient outcomes, as by the authors on the left, is exposure severity, which is self-explanatory in the sense that obviously the more severe the exposure to stressor, the likelier the resilience will be challenged. Individual differences include personality characteristics such as optimism, social support and bonding, being informed, not over-informed and not overexposure to media, emotion regulation and specifically distress tolerance, capacity of the individual, and then looking after themselves physically. Family context is the adaptability of the family to the stresses that the family member experiences, family cohesion, good communication in the family, and financial management during the stressful period. Community characteristics include that the higher the social cohesion within a community setting is, the higher the resilience within the community, lower crime rates, and less disaster exposure also attributes to higher resilience responses. I'll return to some practical ideas around resilience slightly later in my presentation. Firstly, I would just like to sort of explain to you the main aspects of the intervention that is an intervention that can be both done in a group setting and also can be done in one-on-one consultations as a preventative care measure for frontline staff. So firstly, in the intervention, we would describe the varied responses that frontline workers would experience, such as very well articulated in the previous presentation, provide the frontline healthcare workers with a self-assessment opportunity that's online, that would look at key indicators of psychological distress, that amongst others obviously refer to mood, anxiety, PTSD, symptoms, and others, and then provide to the individual or to the group an adapted intervention that covers early intervention methods for responding to COVID-19 and coping strategies to be used by them individually or within the team that they work. And then lastly, to identify the need for a more specialized mental health intervention. Where does this intervention come from? So one is TEX, which is the Toolkit for Emotional Coping for Healthcare Staff. That is a sort of cognitive intervention developed as can be seen on the screen. And then the two sort of disaster management existing programs that is known to most people that were used as a sort of foundation for how we constructed this intervention, which is psychological first aid and skills for psychological recovery, that was developed by the National Center for PTSD of the Veterans Association of the US Army and the National Child Traumatic Stress Network. And then our colleagues from Medical University of South Carolina also developed a resilience clinic intervention, which they shared with us to assist us to develop our own intervention. And then ourselves at the university coming up with our own intervention. So just for those as a reminder, I'm not going to go into the detail of psychological first aid, but just so that you can see how we constructed our intervention. So psychological first aid consists of 8 sort of areas: contact and engagement, safety and comfort, stabilization, information gathering, practical assistance, connection with social support, information on coping, and linkage with collaborative services. This is a very sort of practical intervention aimed at early response on a very sort of practical level. And then skills for psychological recovery, which have 6 steps: information gathering, problem-solving skills, positive activity scheduling, managing reactions, helpful thinking, and healthy connections. So the text core components is the ABC model, a model of emotion, behavior, and thinking. Steps to reframing, changing the thinking to assist people in emotion regulating, and future orientation as a mechanism to help people to be in the moment, but also to see the moment in context in terms of where they come from and where they are on their way to during this COVID-19 situation that we are experiencing. So our intervention was constructed from the previous 3 interventions primarily, and included contact and engagement, which we did by making the service available to frontline workers in different methods so that they can become aware of the existence of the service. Stabilization, information gathering, psychoeducation on stress and trauma coping, activity scheduling that included areas around substance use, sleep hygiene and routine, and healthy connections and nutrition, a component on mindfulness and relaxation, and then a component on cognitive reframing. And then lastly, the linkage with collaborative services. So the intervention is not sequential, it's flexible, and it can be adjusted to the individual needs and concerns of the specific individual or group that is consulted with. So that's the intervention, and that's all that I'll be saying about the intervention today. And I thought, given that we are all involved and all mental health workers working, I thought I will just look at some of the practical things that would form part of this intervention and sort of just introduce some of this to you. So I'm not going to go through all the things in the slides. You're welcome to read as I speak. Some factors, so I think the key thing about resilience is it's not something you're born with, but it is something that can be built by attitudes, behaviors, and social supports that can be adopted. So I think it would be incorrect to speak of we have resilient people and then we have people that are not resilient. We can help people to build towards more resilience if we help them to develop the appropriate skills. So I think one of the things that on the one side serves as strengths and assists people to be resilient, and then on the other side, the lack thereof or having less thereof serves as creating a situation where people have less resilience. So optimism is helpful in terms of resilience, and the ability to manage strong or difficult emotions, or as it would be known commonly, emotion regulation as opposed to emotion dysregulation, is another protective factor. And a sense of safety in this particular case, then in the frontline health workers, both within their community feeling safe, not having the stress of experiencing danger within their community, and of course, important in terms of the healthcare providers at work, providing them with a sense of safety. And as always, a strong social support network is a strong indicator of adjustability and resilience in the face of high levels of stress. And that is a strong social support, both as an individual and within a family, but also to have strong social support within the team and the hospital environment. And then being able to stay up to date with information. So one of the things that I just want to quickly talk about day-to-day functioning in a very busy work environment is the idea of compartmentalizing your cognitive load, taking purposeful detachment breaks, developing mental agility, being able to exercise mindfulness and relaxation, and to cultivate compassion within a high stress environment. And of course, then social connectedness and the importance of family relationships, and then media consumption regulation. As healthcare workers, frontline healthcare workers, I think it's also imperative that people manage their social media and their media exposure to information prudently to prevent themselves from becoming overstimulated by the information, just having too much information and potential risk of exposure to the wrong kind of information. So compartmentalizing refers to the ability to apply mindfulness, which is the ability to do one task at a time and not to try to switch too much between different tasks performed all at the same time, which of course in an ICU kind of care environment can become a really tricky thing to do, but it is about the ability to be single-minded in every moment, even though the moments might not last that long, as you have to switch between patients on a regular basis. Then taking detachment breaks, the idea of not just plodding through, keeping going, but rather being able to be aware of taking a break. And thinking in terms of working 90 to 120 minute long stretches, depending obviously in terms of the type of work that's done, which is followed by a brief moment of detachment, which does not have to be leaving the unit or moving away, but just having a moment of detachment where you can just take a few breaths, practice some mindfulness or other relaxation exercises just to regroup. And mental agility is the ability to respond rather than react to a stressor, such as a difficult situation or a difficult person. And decentering stress is not denying or suppressing the fact that we feel stressed, but rather the ability to pause, to observe the experience from a neutral position, and then to try address the problem. And this entails cognitively stepping away from our experience and labeling our thoughts, emotions, as well as our action urges, and placing the experience in a context. And Linda Graham called this response flexibility and defined the concept as the ability to pause, step back, reflect, shift perspectives, create options, and choose wisely. And one of the other things that's important, we speak to children when they act out and we say, use your words. So when we ourselves experience intense emotion, instead of showing our emotion, being able to express our emotion by using our words, which is one of the ways in which one can effectively utilize emotion regulation, which is valuable in demanding high performance circumstances. Mindfulness, all I'm going to say, as it's a well-known concept, is that preventative medicine research has found that online mindfulness programs is effective in decreasing employee stress. And I've listed a few apps that are either paid or free. The one I think that is very useful is the one from the United States VA called Mindfulness Coach, which is completely free and works through the mindfulness processes of learning mindfulness very well and can be utilized very effectively by anyone. Adaptive coping strategies at work: take more frequent breaks than usual, take a 3-minute break, and then as a group, if we recall earlier on, we spoke about cohesion as a group, allowing yourself to, as a group, connect and utilize compassion exercises and group reflection. And I put this in because I think with protective, with PPE, sometimes using the restroom can be a tricky situation. And a grounding item, but using the restroom is a way of allowing yourself to just have time away. And then grounding items, a photo of a loved one or something with texture or with a smell that you could carry with you that you could be reminded of. I know I'm short on time, so I'll just quickly flash through this. Sleep health, that was well covered. The importance of substance use and monitoring substance use, and then activity scheduling of activities or actions that is in opposition to the negative feelings of anxiety or depression or sadness or anger or frustration. I will conclude at this point, and I thank you for your time and for listening to me.
Thank you very much, Jacko. That was really good. So without wasting too much time, we go next to Eric to follow on this same line of approach, which is what can be done to address this problem of burnout.
I'm going to try, wait, let's see if I can have full screen. No. Yeah, maybe. Are you seeing, what are you seeing?
Yes, we can see your slide. We can see that very well.
Yes? Oh, wow. Perfect. You see slides without comments, without anything? Perfect. Okay. So I'm going to talk about, so along the lines of the prior speaker, I'm going to talk about using mind-body programs and mostly online mind-body programs to support healthcare or potentially support healthcare workers. And just as an just summary of the objectives of the talk. To describe the stress response, I'm going to talk about a concept of relaxation response that does overlap a lot with other constructs that have been described by Dr. Rousseau just a few minutes earlier. And then I'm going to talk about a mind-body intervention that we delivered for other populations, but probably that we could use and adapt for healthcare workers. And just as an introduction, just a couple of things I wanted to tell you or remind you, especially regarding the, or in line with the first presentation. So this is a commentary we wrote with colleagues from Italy, and basically the bottom line is that we need, in order to support healthcare workers' mental health, we need diverse and diversified intervention strategies. In the immediate aftermath and then in the medium and long term. That's another study. It's actually a review we did with other colleagues from Italy also. Again, this one also summarizes what has been discussed in the first presentation. So basically what we did is we reviewed the impact on healthcare workers during other pandemics. And that was right in the middle of the first wave that we did that. And the idea was to get all the information we could in order to prep and to organize support for our healthcare workers. So what we found, again, we found things that are related to the exposure itself. So how much they were exposed to the condition or seeing people being sick. And then everything that is along the lines of the organization of their work. I saw one of the comments a little bit earlier in the chat box that was actually asking the question, how much is it on the individual to protect themselves and how much is it on the organization to protect the worker? So definitely we have variables that really depends on the employers, on the work organization that could help the individual. So how much, how experienced people are, but their specific work, and also the organization and the pressure that they could have on them in carrying out their work. But then what was also interesting is that there are other variables that are more individual, the age, gender, marital status, that could predict how much people will cope with a pandemic. But more importantly, there are individual variables, including coping styles that we can intervene on, which we could intervene on. And so that's why it was really important. So we could, on the one hand, reorganize work, the job setting, etc. But on the other hand, we could also intervene at the individual level. In just a summary of what happens when someone is exposed to a stressor. So that's a cascade of the stress response. I'm not going to get into the details, it's a little bit boring, but basically you get stressed, you have stimulations that increase your arousal, and at the end of the day, that's the bottom of the cascade. You have increased heart rate, increased blood pressure, increased metabolism. And the idea is that we should try to block that stress response. And blocking that stress response will block the perceived effect of the stressor, a negative effect of the stressor. So I won't spend too much time on mindfulness. So there's other definitions of mindfulness, including, I like this one. So mindfulness means that we pay attention in a particular way, on purpose, in the present moment, and without judgment. And why am I talking about, and just to clarify mindfulness, mindfulness is not trying to ignore negative thoughts or feelings, like avoid, but instead to pay attention with kind awareness without getting caught up in the content of the thoughts, but just thinking, oh, I'm fearful here, and then just let it go. So why am I talking about mindfulness? Because there's another state that has been described quite some time ago by colleagues in Boston called the relaxation response. It's actually a bestseller of 1975 and a few years later, describing relaxation response. So that's Herb Benson who described that. He's, I don't know if you know him, but he's a cardiologist, and then he started to study the physiology of monk meditators and realized that these people could actually by meditation, changed the metabolism, their metabolism and their heart rate, etc. So that's kind of, he created or he coined the this term, the relaxation response. And so basically the relaxation response is a state that is opposite to a stress response, and that is a state that results from mind-body techniques such as mindfulness meditation, as I mentioned, or other types of mind-body interventions like yoga. And there's emerging data showing that eliciting the relaxation response could reduce inflammation, stress, including at the genetic or epigenetic level. All right, and so that's a description of what the stress response will be and what the relaxation response will be in the cascade. And so basically it's really it really works in mirror. And just, I won't spend too much time showing data, but this is just to illustrate how mindfulness and mindfulness-based intervention could work. And this is data from a meta-analysis showing that mindfulness interventions would work for post-traumatic stress disorder. And I chose PTSD because of the stress component of it. So back to the intervention or specific intervention. My colleagues or former colleagues in Boston created that intervention called the SMART program, stress management and resilience, SMART and resiliency training program, which is an 8-week multimodal mind-body program, including relaxation response techniques, so meditation, for example, but also adding some cognitive behavioral skills and some elements of positive psychology or acceptance. And they developed that program to help people cope with chronic stress. And so if we think about someone who's stressed right away because there's a one-time stressor, that's one thing, let's say in a, I don't know, accident. But if we think of healthcare workers during a pandemic, we're talking about something that is more along the lines of chronic stress. And so technically, if we look at the different problems that healthcare workers under stress may perceive, including the stress response in itself, feelings of loneliness, lack of social support, unhealthy behaviors, negative thoughts, negative cognitions, negative affect, then we can see that the SMART program has components targeting all of these different pieces, negative constructs, negative outcomes. Now, we haven't at this point adapted yet our SMART program for healthcare workers. However, what I'm going to show you is how we, a couple of years ago, were able to adapt it and tailor it for another population of chronically stressed people who are, in a sense, very similar to healthcare workers. So I'm talking about caregivers. And specifically here we had a small grant to create that intervention and study it among military caregivers. So military caregivers are people who care for, let's say, their spouse who is a military veteran who's sick or injured, and usually they're caregivers for years and years. And so what I wanted to do is, in order to adapt the SMART program, which is an 8-week treatment in group, in person, for military caregivers, we first did a couple of focus groups. And the idea is that we didn't want to create an intervention and then test it in a research environment, finding that it works, and then trying to disseminate or implement it and realizing that nobody uses it because it's not convenient for them, because it's not feasible. So really we wanted from the start to be able to create the intervention, to co-create the intervention with the end users. So we did 2 focus groups with military caregivers, And the aim was to evaluate feasibility, acceptability of the content of the intervention, and also how we could adapt it for them and specifically for them. So we conducted the focus groups virtually, and that was pre-pandemic. So we did everything over internet. We audio taped it, we transcribed and did content analysis. This is just a description of the population. We have 13 military caregivers. Whereas on average, they had 40 years of age, mostly women. And as I said, on average, they've been caregiving for their loved one for 8 years. And this is what we found from the focus group. We found that they all loved the program, that it was very logical, that they thought it would be very helpful, that they thought that they would be willing to participate in it. But they were they also wanted an online version of it. So we worked with them a little bit, and what we did is create it or adapted it into an online version, doing first some content manual, like the treatment manual adaptation and content adaptations, so that it was very specific to them and was speaking to them. So for example, wordings will change into, it's always important to take care of yourself, to be able to take care, for you to be able to take care of your loved one and things like that. And then we also adapted, more importantly, the format so that it becomes an online delivery. And what is more important is that our focus groups said that they didn't want any screen time. So I know we discussed just a few minutes ago mindfulness-based apps, and lots of them are great, but this particular group of people said that the apps are very distracting, and with the screen, lights, etc., they found that it was too arousing rather than soothing. That's all they said. So what we did was create an intervention. I actually forgot one other thing that they said that it's not on the slide just before, is that they also said that what is important for them, that they couldn't commit for 1 year, one hour a week. That's not possible. When you work and then when you take care of people, you're exhausted. There's no way they could commit 1 full hour, ever. Actually, they will never have 1 full hour for themselves. They also said that, I forgot what they also said. It will come back to me. Oh yeah, they also said that they needed accountability, that they need a way to keep engaged in the intervention. So what we did is that we adapted the content of the manual, which was, as I told you, 8 sessions of 1 hour, 1 hour and a half over 8 weeks. We created instead an intervention that was delivered each day for 28 days and in a form of a podcast. This is a picture of my colleague who was actually recording one of the podcasts. And the podcast included the same pieces, or most of the same pieces of the normal intervention, specifically psychoeducation about stress response and ways to decrease it, relaxation response practices, and appreciation practices, just as the prior speaker mentioned. So the program looked like this one. This is actually the breakdown of what we offer. It's a little bit small. I'm not sure you see, but so day 1, there'd be 60 seconds of intro and then program overview, stress education, 3 minutes of appreciation, 30 seconds of send off. And so every day they had something, and we're building over time their mindfulness, relaxation response practice, as well as their appreciation, self-compassion practice. So what did we find, or what did we do? So we were able to screen 112 participants. Of those, 107 met criteria, and 55 were actually enrolled, like completely completed baseline surveys, and then we followed them. At least 38 completed one other time point. We assess a number of variables, including perceived stress, depression, anxiety, quality of life, and also mindfulness, just mindfulness as a construct. This is just on the left, you have the where the participants came from. It's a hotspot in Florida, but for those who have been in the US know that Florida is concentrated in military population. It's just a description of the population. I don't think we need to get into it, but this is for the paper that is under review now. They wanted the full sample, and then those who dropped and those who stayed in the study, but we didn't have any significant difference here. So on average, participants listen to 16 of the podcasts, so that's not that many. However, some of them were listened more than once. Just on the left, the download data, and so it was delivered over a month. And as you can see, people kept downloading over the month, and then people stopped downloading after that. So really people engage in that. In the middle is just the type of devices they use. And on the right is a snapshot of how it looked like on the phone, the podcast. And these are the results. We run a mixed model here with time as a variable. And what we found, and so we accounted for all the data, we used all the data. And here what we found is that people significantly decreased their perceived stress. That's the first one, PSS, the depression symptoms, MSCL are the somatic physical symptoms like back pain, headaches, etc. And promise A is the ability to participate in social roles. And as you can see, perceived stress, depression really decreased by quite a bit. Like it's a pretty large effect size. We also asked people who completed how they felt about it, about the program, and 9% felt they were satisfied with it, that they were, so over 9% indicated that they were satisfied, that they would recommend the program to a friend, that it helped them deal more effectively with their problems, that they would return to the program because they had it on their phone. And that's really the type of services that they wanted. And I think I'm pretty much done. So just to conclude here so that we can have some time for discussion, we think that the mind-body intervention is feasible, acceptable, and may support resilience among caregivers. The adaptation of this particular program or similar programs, or even the PFA that was mentioned a bit earlier, but broken down as a podcast or mobile intervention, could help healthcare workers exposed to the COVID-19 pandemic. And kind of the same, like using podcasts would definitely, or other things like that, would definitely support broad dissemination. I think that's it. Thank you very much for your time.
Thank you very much, Eric. That was really informative. Thank you very much. So we have about 20 minutes for question and answer. And as been announced at the beginning, you can place your question in the question and answer box there on the platform. So before we get, I think we have a few questions already. But before we get to those, can I just ask one or two questions of the panelists myself before we begin to address the other question? And this one is for Jaco. I was quite interested by the sort of range of risk factors and so on that you describe in terms of factors that might mitigate against resilience and the ones that can build resilience. I think you mentioned things about being challenged, which I imagine is something like a stress inoculation, that's people exposed to previous stress might be able to acquire some what you describe as a resilient skill set. But talking about healthcare workers then, how will the predictors of resilience apply to this group of people in terms of the place where they work? How will the predictors that you have described? I think you also mentioned something about information overload, and especially in terms of the need to stay informed, but also the need to avoid excessive media coverage or media exposure. Can you please enlighten us on those predictors in terms of how they apply to frontline health workers?
Sure. I think it's very similar in terms of the outside of work setting, as mentioned earlier in the slide. But I think things that was mentioned by our first speaker was the more the direct contact with the COVID-19 patients are, the higher the risk and the more they will struggle with resilience. So direct contact with COVID-19 patients, and then specifically a risk group is female nurses that have direct contact, as was also mentioned earlier. And I think the factors that perhaps are hopefully mostly sorted out in most places that also causes difficulty is that there's insufficient instruction in terms of safety and procedures and routine that also serves as a factor that causes more challenges for people and lowers resilience. And then some studies also found longer working hours. So if people's hours are extended, that also serves as a problem. So those are all sort of maybe unique factors specific to frontline health workers.
Thank you very much. I know that Eric mentioned this briefly in passing, but there is a question from Julian Eaton asking about what responsibility do health service leaders have to protect workers' well-being, and how much is it the responsibility of workers themselves? And how much is it about improving work situation or reducing stressors? And how much is it about providing guidance for self-care? I'm asking this from Dr. Oladeji because I know that the last slide that you showed had some workers that demonstrating with placard held up and asking their employers to protect them. So the question from Julian is, what is the kind of shared responsibility in this context? Is it much for the health workers themselves, and how much of it is really for the service leaders?
Thank you so much for that question sent by Julian. And one thing I would like to say is to put things in perspective. Since burnout is largely a result of the unresolved work-related stress, so it will be important, and that is the work of the service managers, as much as possible to find a way of reducing the work-related stress that the workers are exposed to in order to protect their mental well-being. The intervention is just a part of it. That is intervention for individual health workers, which has been discussed by Eric and Jaco. But the key thing, the service managers need to find ways of reducing the stress in the workplace. And one of the things that came up is the fact that when workers are drafted to work in those wards, it is more stressful for them compared to those who are allowed to volunteer. So where the number of health workers available allow, as much as possible, workers should be allowed to choose whether they want to work on the front lines. But one thing that would aid workers being able to work on the front line workers that perceived that they had adequate training for them to be able to work in those areas, they were less stressed compared to those who felt untrained, and so they felt incapable of handling what was going on the front line. So I guess having a lot of provisions for training, and the training for some of the literature that I reviewed, that this training should start long before the disaster is anticipated, so that the workers are prepared before the disaster comes. Not, like this is already upon us, and then that's when we're now trying to, like, for example, now a lot of countries are experiencing an upsurge. This is the time to begin to prepare workers to work in the front lines, not when the upsurge gets, gets to a peak. And another issue is the issue relating to being protected. So where workers have adequate PPE, which is largely a responsibility of the management of the service managers, they also feel less stressed up. So those are some of the things that then the workers' time off should be cherished. When workers are supposed to be off on break, they should be allowed to take their time off. And I think this pertains more to the nursing staff, because they are mostly at the front line. They bear a lot of burden of working directly with patients. So their time off should be respected, and so that they can have time to kind of recuperate before they get back to work. So I think the service managers have a lot of work to do in protecting workers.
Thank you very much. And this is for Eric. You describe in detail the mind-body approaches and mindfulness, and also some of the studies that you have done to explore the use of these approaches by caregivers and their ideas about their reflection on having received those kind of approaches. So I was just wondering, how do these approaches differ from traditional psychotherapy or medications? How are these? How do they work? In what way do they work differently from traditional psychotherapy or medication?
Yeah, thank you for your question. Actually, I think that the way they work, we're not quite sure how. I mean, they're definitely different, because the concept is really to use your body in addition to your to cognitive processes. But there's things that are very similar among both. One thing that I would like to highlight when comparing both is really that at this stage, we know that mind-body approaches, yoga, work better than controlled condition, like just psychoeducation. But there's still a lot of work to be done to know how much they compare in terms of efficacy with, let's say, cognitive behavioral therapy or medication. We just completed a trial comparing yoga, Kundalini yoga, compared to stress education, so psychoeducation, compared to cognitive behavioral therapy, traditional cognitive behavioral therapy, and that was for generalized anxiety. And what we found is that yoga, Kundalini yoga, 12 weeks of Kundalini yoga works better than psychoeducation, than 12 weeks of psychoeducation. But not quite as well as cognitive behavioral therapy. Now, we also have an ongoing trial now comparing, or trying to compare, mindfulness training to medication for stress, to antidepressant, like FDA-approved medication for anxiety, all types of anxiety. So we'll see how it goes, but I think there's still lots of debate as to where this intervention can fit into the normal healthcare system, either as a complement or as an alternative, or maybe just as a start, as a first stage, because it's also more available, like trying to find a psychiatrist to prescribe medication, antidepressant, or even finding a cognitive behavioral therapist like Jaco. They're not everywhere. So that's kind of difficult to find. So even if mind-body interventions work not as well, they may have a role to play as a first line are as waiting. Yeah, but there's still lots of work to be done around that.
Thank you. We have a few questions on the question and answer platform. I think we can take all of them, just 4 of them at the moment. There's a question, this very quick one to Dr. Ladeji from Goodluck Msele, who is asking whether there are any studies done in Africa on the effect of burnout in healthcare workers due to COVID-19. Are you aware of any such studies done in Africa?
Unfortunately, I couldn't lay my hands on any when I was preparing for this. And it was even so also informative that even from Ebola, I couldn't really lay my hands on any that provided prevalence of burnout even after the Ebola crisis. So there is a lot of gaps in terms of African literature. So I don't know if any of the panelists has any other noticed any. I couldn't lay my hands on any.
Right. Okay, so I suspect that, I mean, those Ebola, for example, might have not been as adequately explored by local researchers in the countries as one might have expected. The next question is from Kulibali Nabembi, who is asking, I think Jacko can help us with this. Is asking, or he or she is asking that, how do we deal with a colleague who is emotionally sensitive and whose teamwork spirit is poor in the context of COVID-19? How do we deal with a colleague who is emotionally sensitive and whose teamwork spirit is poor in the context of COVID-19? Do you have some suggestions for Kulibali?
So I think that is where it can get tricky, because of the referral source would have to be from within the team, and how to describe the importance of offering the help to that individual without the person experiencing themselves as being labeled or as being identified as a poor team player is the key. So I'd say people who do struggle with emotional sensitivity, as we all referred to earlier, will struggle with being emotionally vulnerable in higher stress environments, and would benefit from some kind of an intervention that would help them to increase their resilience or increase their emotion regulation skills. So one way would be from within the team to allow for an appropriate referral. And the other way, something that has been done successfully within a COVID-19 context in hospital settings is compassion practices. So it's led by 2 individuals, and the compassion practices specifically focuses on spending time as a team together, expressing compassion towards colleagues in a very sort of structured way that they are assisted to participate in, which might be a helpful way for someone who's emotionally vulnerable to also feel cared for and supported within their team. Because obviously the natural response for people towards someone who's emotionally sensitive is to start avoiding that person and isolating that person even more within the team, which can just cause even more problems for them.
Oh, that's excellent. Thank you. But this actually also is to you, and it's from Emmanuel Gite. I hope I pronounced the name correctly. Is asking you to expatiate, if you can, please, briefly on emotion regulation techniques. Can you provide a little?
So perhaps just because of time limitations, I'll just refer to dialectical behavior therapy skills that are used with people who struggle with emotion regulation, not just borderline personality disorders, but many other people struggle with emotion regulations and are slower to return to baseline and experience a higher peak in emotion. And the techniques that one can use with people who struggle with emotional sensitivity and reactivity is very well described within the adult and adolescent skills manuals produced by Marsha Linehan and also by Miller and Rathis, who developed the adolescent skills manual. So I think I'll just refer Emmanuel to the DBT skills manuals, because it's very well described there.
Thank you. And Eric, I suppose you can help us with this question from Margaret Ayorinde. She's asking, how can one reduce fear of healthcare workers? I suppose in the context of being drafted to infectious disease unit, how can we reduce the fear of such workers?
How can we reduce what?
The fear that they may,
Yeah, I think that's the thing where it probably comes also from the employers and how people can provide the equipment and all that. I think it does also have to do with leadership on the ground, and I've seen places where people are more fearful of going and they wouldn't go first, like on the front line, and see other places where people definitely also have the same equipment, but the atmosphere is different because the leadership would just show the way. If that's what you mean by fear, right?
Yeah, thank you. Just as a final one, perhaps Dr. Oladeji can help us with this question that I'm just going to ask, which is, you listed quite a range of health workers that might be at risk of experiencing burnout. But you did also mention that the risk status is not similar across the groups. So which of these groups of health workers are actually at the highest risk of experiencing burnout from your reading of the literature and your experience?
Thank you. Across all the literature reviewed across different contexts, the nurses were at increased risk for burnout compared to other cadres of healthcare workers. And part of the things that was specifically reported is probably because they have longer contact hours with the patient, so they actually have to use the PPE, which is a major source of stress for most health workers for a longer period. So the nurses are increased risk. So then, in addition to all that, they felt that probably the longer duration of training for physicians was one of the reasons why they had lower perception of stress. So probably interventions for the nurses will be very, very important across every sector, across every healthcare system. So interventions that will reduce the stress that nurses are exposed to, in addition to specific interventions for individual nurses, like some of the things that Eric and Jaco have spoken about, to be important, especially for the nursing staff.
Right. Thank you very much. We've come to the end of the session. I would like to express my deep appreciation to the panelists on behalf of CDC. And I wonder whether Dr. Abdulaziz.
Okay. Thank you very much, Prof. Dr. Malik, can you unmute your mic? Prof, you can go ahead now. We can hear you clearly.
Yes, I was just thanking the panelists for a wonderful session and all of the people who have made our time to attend. This has been a very informative session. And I was wondering whether you would have any closing remarks you wanted to make, or maybe we just close the session.
Okay, thank you, Prof. We really appreciate your chairing this session, and my sincere appreciation also goes to all the participants. Only to say, Prof, and definitely the panelists, Dr. Eric, Dr. Jacko, Dr. Oladeji, thank you so much for the wonderful discussion on this session. We also thank Professor CIRRI for all the work she has done in organizing this webinar. So only to say that we see you same place next week for another session that promised to be very, very interesting. Thank you, and see you next week. Bye-bye.
Bye-bye. Thank you.
Bye-bye.
Thank
Thank you.
everyone.